Good morning, everyone. Thank you for having me again at one of the Orbis cyber site, and thank you, the audience, for joining us. Today, we're going to talk about the update on medical treatment for infectious keratitis. So these webinar doesn't necessarily go over specifically, how to diagnose or treat or what is infectious keratitis, but mostly going over what are the new concepts or relatively new concepts that we've learned through the literature in the past few years, and what is the future, and what are the things that we need to be looking at, to incorporate into our practices in the future to be better at diagnosing and treating infectious keratitis or more effective. So my disclosures have no financial disclosures for this talk, but we are going to talk about some treatments that their use is off-label. So what is the global picture? Infectious keratitis is a significant burden for the world. In fact, we think that corneal disease is the #1 cause of monocular blindness in the world, and it typically affects marginal populations the most. Infectious keratitis is the main cause of corneal opacities and the 4th cause of blindness in the world. And it's responsible for 10% of all the preventable causes. So if we did a better job at preventing infectious keratitis, we could significantly decrease the burden of corneal blindness. So this is the first poll questions. We're just diving right into it. And the question is, what is the gold standard for the diagnosis of bacterial keratitis? All right, so I like it. Yeah, the gold standard. I think still in this day and age, despite of all the pitfalls, gram stain and cultures, it is the gold standard for diagnosing bacterial keratitis. But I think there are other modalities that are gaining traction, and I'm going to talk a little bit about what the future holds. But, obviously, we all want a fast and accurate diagnosis so that we know what we're treating, we can treat it fast, and we can achieve resolution as soon as possible. So not just for not just for bacterial keratitis, but in general, for all keratitis, gram-Giemsa and stain cultures are still sort of our gold standard. The problem is their low sensitivity. When they're positive, the specificity is excellent, but they're not always positive, and they leave us treating an infection that we really don't know what organism is causing it. But in general, they have pretty good specificity. We can use different media for different bacteria, with blood and chocolate, more common for bacteria than for fungal. We can use VHI, or for subrats, for acanthamoeba. We can use blood with E. coli overlay, and so different medium depending on what is the organism we're suspecting. PCR, we typically use PCR mostly for viral infections, but we're going to talk a little bit more about broadening its application to perhaps fungal and bacterial keratitis. And for the diagnosis of viral keratitis, it is largely clinical, and most of us don't typically do any confirmation. But if we were to do PCR on this, just because the dendrites are so characteristics that sometimes we don't need a confirmation, but in those equivocal cases, we could do PCR, and it has a very high sensitivity and specificity. We can use confocal microscopy, like the image on the right. It typically is able to diagnose larger organisms. We're able to see acanthamoeba, filamentary fungus, and nocardia. Anterior segment OCT is something that's been proposed as well for the diagnosis of certain keratitis. More than for the diagnosis, it's to follow them up in a more objective measure. So we can objectively measure the size of the infiltrate. We can monitor for thinning during treatment and such things. So let's talk a little bit about PCR for infectious keratitis. What are the advantages? Well, it has a high sensitivity compared to culture and staining, which is the main drawback of the culture and the staining. It has the ability to test for antimicrobial resistance. So right off the bat, we would know, if these microorganism is resistant, and we would know what to treat it with. It can be performed pretty quickly, within 4 to 8 hours, whereas for the cultures, you at least need to wait 24, 48 hours. And if it's a fungal organism, probably days or weeks. It is shown to be more cost-effective with selective use than culture and staining. This was surprising to me. It is a lot more expensive than culture and staining. But if it's going to decrease the burden of treating all those patients that are misdiagnosed and end up with a severe keratitis, so the cost of treating those patients is much higher than actually applying PCR. So it is, a thought would be that for those areas where they have a high incidence of infectious keratitis, perhaps a center that performs PCR for all those patients might be cost effective. There's increased availability to detect less common organisms, such as viruses, for example. But it does have some disadvantages, and that's why it is not yet applied, everywhere, and we use it sporadically. It can have lower specificity compared to culture and staining because it basically will give you everything that's there. Need for a narrow list of causative agents to use specific primers. So you have to select and tell them, okay, I want you to test for staph, or I want you to test for Pseudomonas, or I'm looking for, Candida or Aspergillus or whatever. It becomes less cost effective when it's performed with a multi-organism PCR approach. So if you're looking just for HSV, that's easy, very cost effective. But if you're gonna send a large list of potential organisms, that makes it less cost effective. And supply costs, of course, machinery fees and training expenses need to be taken into account. So what's the future of diagnostics? I still think PCR is going to play a large role for the diagnosis of bacterial and fungal infections, but we need to get better at validating this procedure, at having better protocols for the sample collection and diagnostic thresholds, and of course, we need to reduce the cost. Another interesting technology is next generation sequencing. These technologies developed to determine DNA sequencing. It's associated with bioinformatics to detect pairs between the sample that we've collected and a gene sequence database. It has the potential to determine the etiologic agent with a lot of precision and very fast. And it does not require primers like PCR. So potentially the application could be wider. And then anterior segment OCT. This is, I thought about including this because it's something interesting. Maybe we're not using these to diagnose cytomegalovirus endotheliitis, but it's a nice, sort of confirmation or adjuvant test that we can do. So in the area where you see those typical coin lesions for your endotheliitis by CMV, if you do OCT, you actually will see a thickening in the area of Descemet's membrane and the endothelium. And you can almost see right here, the large, cells if you do high resolution, at high magnification. And then confocal microscopy also can be used. We talked about confocal microscopy for the classic indications, which are acanthamoeba, nocardia, and fungal and filamentary keratitis. But CMV can actually also be diagnosed with confocal microscopy, where you can see the owl cells, those large cells within the coin lesions right here. So our next poll question is, which of the following organisms is most likely causing this corneal infection? All right, yeah, the answer is acanthamoeba, but I like it that everybody answered acanthamoeba because that's the thing about confocal microscopy. It depends on who's doing it and how we interpret those images, and it's not always very clear cut, and sometimes we're going back and forth and looking at multiple images and trying to figure out, is this something or is it not really something? But in this image, you can clearly see the cyst with the wall. All right, here, here's another one. There's actually a lot of cysts in this image that give you the hint that this is indeed Acanthamoeba keratitis. What about the treatment for bacterial keratitis? What have we learned recently? Well, we largely treated with antimicrobials. It is the first line topical antibiotics. We have a choice between a broad or reduced spectrum antibiotic. We take into account the cost of the medication we're giving, the toxicity, its availability in the country or area that we're at, and we want to target specific pathogens according to the area that we live in. So there was this Cochrane review done by McDonald where he looked at 16 studies that were comparing 2 or more antibiotics that were given for at least 7 days or more. And he showed that no matter what antibiotic was used, they all had similar efficacy and the same risk of adverse events. It did show, though, that there was some antibiotics that had a relatively minor higher risk of toxic conjunctivitis or discomfort. And not surprisingly, aminoglycosides were the ones with the most adverse events in terms of toxic conjunctivitis, followed by cephalosporins, and lastly, the one that most of us end up choosing because it's low side effects is fluoroquinolones. These graphs show us or gives us an idea of the initial antibiotic choice for bacterial ulcers in the US and in international areas. This was done by a survey, and we see that largely in the US for severe ulcers, vancomycin and tobramycin is preferred, with 54% of corneal specialists using these antibiotics. Whereas internationally, the first choice would be monotherapy with a fluoroquinolone. What about resistant organisms? So not everything responds to our initial antibiotic. The CDC actually estimates there's at least 2 million infections a year by resistant organisms today. 80% of methicillin-resistant Staphylococcus aureus in the United States is actually resistant to fluoroquinolones in ocular samples. So we look at all the ocular samples, all the MRSA that we recover, 80% will not respond to fluoroquinolones. In the steroid for corneal ulcer trial, actually we saw that in vitro susceptibility correlates with clinical results. So for antibiotics, susceptibilities, if it says it's resistant to the antibiotic, most likely the infection will not respond, despite the fact that we know that antibiotic sensitivities are based on blood levels of these antibiotic when administered systemically, and we know that we do achieve much higher concentrations in the eye by the application of a fortified type of antibiotic topically and more frequently. But I think it is still recommended to obtain cultures and sensitivities in all corneal ulcers, and particularly those for this very reason, because we're having a significant rise in resistant organisms. We, of course, are going to evaluate the response to treatment, and if things are not going the right way, we may change perhaps an initial monotherapy with a fluoroquinolone to fortified antibiotics. But if the initial therapy actually already includes fortified antibiotics, then we have to consider other things. It is pretty unlikely that one of the organisms that we're treating will be resistant to, say, fortified vancomycin and fortified tobramycin. So we need to consider toxicity as an impediment for reepithelialization of the cornea. And so perhaps instead of intensifying therapy, what we need to do is reduce the frequency of application to allow the epithelium to heal. So this is our next question, and is, what is the treatment of choice for methicillin-resistant Staphylococcus aureus keratitis? Perfect, vancomycin. And yes, this is correct. It is a little bit of a tricky question because vancomycin has a very narrow spectrum, mostly gram positives, and it is the treatment of choice as of today, for methicillin-resistant Staph aureus, we are starting to see probably more in systemic infections and not so much in the eye, although cases have been reported of vancomycin-resistant Staph aureus. Linezolid for these cases would be an option. It is another drug with similar narrow gram-positive spectrum to vancomycin. It is significantly more expensive, but can be used if there is allergy to vancomycin, for example, or toxicity in some way to vancomycin. Moxifloxacin, like we talked about, at least in the US, high rate of resistance from MRSA to quinolone, so it wouldn't be a treatment of choice. And tobramycin is mainly gram-negative spectrum, so it can be adjuvant in certain infections. It's not the treatment of choice as a monotherapy. So if we talk about MRSA keratitis, okay, we decided vancomycin is the treatment of choice, but how much vancomycin? What is the ideal concentration? Do we need to give vancomycin 5%? Do we need to give 2.5%? Do we need to give 1.5%? What exactly is the concentration that would be better? And this is a study that was recently published in Cornea. It is actually a study done in rabbits. It's not a human study, but basically what they did is they infected the corneal, the rabbit corneas with MRSA, and then they treated it, and they looked at the different concentrations, and they found that the most effective concentration is still the 5%, 50 milligrams per cc of fortified vancomycin. However, this one is also the most toxic. They saw that lower concentrations appear to still be active, but they need extended therapy. So you need to use it more frequently and for a longer period of time. The main concern about the higher concentrations is that it burns when you put it in, and it has toxicity to the epithelium. So because it burns so much, sometimes non-compliance is an issue, and that may delay resolution. And also, if we have delayed epithelial healing because of epithelial toxicity, that could also delay the resolution of the keratitis. So how to reduce the inflammatory response? Because largely, and unfortunately, infectious keratitis continues to be a significant burden in the world, because it will give residual opacity that permanently affects the vision and can cause severe complications like necrosis and perforation, requiring therapeutic keratoplasty and with permanent sequelae in these patients. So how can we reduce the inflammatory response and hopefully reduce the necrosis and the residual opacity so that we can reduce the burden of disease? What are the factors that could reduce inflammatory response? Well, one of them, or at least one of the drugs that has been proposed, are anticollagenases. The goal would be to reduce the lysis of tissue, therefore end up with less perforations and less rate of therapeutic keratoplasties. Tetracyclines are largely what we're talking about when we talk about anticollagenases. They do inhibit collagenases and have an anti-metalloproteinase activity in vitro. There are 2 studies, again, these also have been done in rabbits, that showed a significant reduction in ulceration and risk of perforation. But unfortunately, there are really no randomized clinical studies in human that guides the use of tetracycline. Relatively safe drug. And I feel that we all use it despite the lack of strong evidence for it. But we all, at the risk of melting and perforation for various corneal diseases, not just infectious keratitis, we may decide to use tetracyclines orally. And then steroids. This is the eternal debate, right? So most of cornea specialists feel that steroids are largely beneficial for corneal ulcers, or for most corneal ulcers. There's always the concern, though, about why we think that. We think that it helps reduce scarring, neovascularization, and stromal lysis. The disadvantages is the delayed reepithelialization and worsening, and potential worsening of an infection, and that's why sometimes we're scared to start steroids. So it's always the eternal debate. And what is the evidence? So there have been several studies, high quality studies performed to try to answer this question. When I looked at this Cochrane review, actually, we found really 4 studies that were randomized studies that used antibiotics plus or minus topical steroids. Unfortunately, 3 were too small, not necessarily powered to show a difference, but there was one study that had enough power to detect differences, and this was this steroid for corneal ulcer trials. So this review concluded that unfortunately there's not enough evidence to recommend its use in clinical practice, but I think it's worthwhile to look at the SCUT study, and we're going to answer this next question, and then we're going to go into the SCUT study and see what we really learned from it. So our next question says, in which, let me see, I can't quite read it. Let me go here, sorry. In which of the following organisms are topical steroids contraindicated? This is actually part of what we learned from the SCUT study, so that's why the question is here. Right, so this is good that we're going to go over the results of the SCUT study. The correct answer here is actually nocardia. A little bit of a tricky question because acanthamoeba was not tested in the SCUT study because it's not a bacteria. This was only for bacterial keratitis. And steroids are sometimes used in acanthamoeba and are needed successfully, but it's also, you know, one of the organisms that we always want to be cautious about. But let's talk about what the SCUT study showed. This is a steroid for corneal ulcer trial. It was a multi-center randomized double-blind study that compared topical steroids as an adjuvant versus placebo, 500 participants with culture-positive bacterial keratitis. So we already knew this was bacterial. We didn't include anything else. And what the drug used was prednisolone sodium phosphate, and this is so that it's not milky and white, and it looked just the same as the placebo. It was started 48 hours after starting topical moxifloxacin, and the dosing was 4 times a day. The results show that in general, the study doesn't show a significant difference in opacity or the rate of perforation in these patients. So whether they use steroids or they didn't use steroids, these 2 endpoints did not change for all patients on average. So this was surprising. We all could have bet that opacities were going to be less, that, you know, perforation was going to be less. This was not the case. But we did learn that it did benefit in certain subgroups. For example, patients with low visual acuity, less than count fingers at presentation, patients with central ulcers, the central 4 millimeters, and patients with deep ulcers, we saw that those that were randomized to the steroid group had better visual acuity at 3 months. We also saw that the type of organism was important. We saw that nocardia, which was 10% of all the patients included, had worse visual acuity if they were given steroids. That's why I was asking the question about which one is the organism in which steroids are contraindicated, and it's for this reason. We saw that largely, if you look at all Pseudomonas cases, steroids didn't make a difference. But if you look at Pseudomonas of the invasive subtype, we saw that they ended up with better visual acuity at 3 months if steroids were used. And we also learned that timing is important. We saw that the earlier the steroids were started, within the first 2 to 3 days, then the better the outcomes. So what are the take-home points on steroids that I can gather from the evidence that we have? Well, I think that as a result of this subgroup analysis, we could recommend that the use of topical steroids in bacterial ulcers, we could recommend the use of topical steroids in bacterial ulcers, except on patients that have nocardia, and we should start them relatively quickly, 48 hours after initiating appropriate antibiotic therapy. This is the recommendation. Some other data, and this is kind of, there's a few studies out there now that are showing that maybe we didn't see a significant result in the SCUT study overall because the dosing of the steroids wasn't enough. And when they compare low dosing, like twice a day, of topical steroids with high dosing, more than 6 times a day, they saw that those that have a higher dosing of the steroids had a significant better visual acuity. And these are not large studies like the SCUT study, but it's a concept that's beginning to gain traction, and we are going to need to look at it in further studies to confirm exactly what's the optimal dosing for those topical steroids in bacterial keratitis. What about fungal keratitis? Well, we know that it definitely has worse outcomes than bacterial keratitis. There's less evidence to guide treatment, and it is largely more common in tropical climates where it represents almost 50% of all the ulcers. Here in the US, contact lens use is a significant risk factor, and we've had a couple of our contact lens solutions removed from the market for this reason. So what are the options for topical treatment? Well, unfortunately, at least here in the US, natamycin was approved by the FDA in the 60s, and we haven't had another approved topical antifungal for the treatment of fungal keratitis since. So it is effective, but it has limited penetration. Amphotericin B needs to be compounded, and it can have, significant epithelial toxicity, but it's in general effective. And Voriconazole has a good ocular penetration, and it has very good antifungal effect in vitro. But we're going to learn that sometimes in vivo that is not the case. So our next question is, what is the topical treatment of choice for fusarium keratitis? Good. So the majority, 60%, picked natamycin, and I think that's what the what our latest studies have shown, that unfortunately we thought the Voriconazole was going to be a great drug, and it didn't seem to have such good clinical effect as we expected. So let's go over the MUTT trial, which is the Micotic ulcer treatment trial. And again, it's a randomized, double-blinded, multi-center study, so it hits all the keywords that you want to see on a well-designed study to answer this sort of question. And it basically looked at natamycin versus topical Voriconazole for the treatment of mycotic ulcers. Mostly filamentary fungus, especially fusarium. So there were 323 patients included, but the study control had to stop the study because they showed that the group treated with Voriconazole showed a higher rate of perforations and need for therapeutic keratoplasty. So actually the study had to be stopped. So this is pretty interesting. We did not expect this. What did the results show? Well, natamycin had better visual acuity at 3 months, mostly in fusarium ulcers. There was less corneal opacity at 3 months. At 3 months, this was only for fusarium ulcers. And there was a reduced number of positive cultures 6 days after treatment with natamycin. So we concluded that natamycin is superior to Voriconazole in all filamentous species. There was a second randomized study and a Cochrane review that actually confirmed these findings. So I think we can say that natamycin is at least the initial treatment of choice for fusarium keratitis. Now the problem is the penetration into the cornea. So if we have a very deep ulcer, then perhaps we're going to have to look at some alternative therapies because natamycin may not get as deep to treat this infection. So then then it was thought, well, perhaps the MUTT I trial didn't do so well because the concentration of Voriconazole in the cornea is not as stable, and perhaps oral Voriconazole would be better and provide us better therapeutic levels to the cornea. So the MUTT II study was created to compare Voriconazole levels in aqueous humor. I'm sorry, not to compare Voriconazole levels in aqueous humor, but the basis of this study was that there were studies showing that the levels inside the eye, particularly in aqueous humor, were better if Voriconazole was administered orally than it was administered topically. So The study design was patients were treated with their topical antifungal, and then Voriconazole versus placebo orally was given to all of these patients, and they were randomized for each arm. And it did not show a difference in visual results, rate of perforation, or need for therapeutic keratoplasty, whether they had oral voriconazole or placebo. But we did see significant more adverse events in the group that was randomized to oral voriconazole, and that's to be expected, increased in liver enzymes and visual disturbances. Subgroup analysis showed, though, that there might be a possible benefit of oral voriconazole, particularly for fusarium ulcers. What about adjuvant treatments? Okay, we're not able to resolve this infection with our topical or oral treatment. What can we do? Intracameral and intrastromal amphotericin and intrastromal voriconazole had been proposed and are pretty widely used for the treatment of fungal ulcers. For intrastromal voriconazole in particular, some studies showed a possible benefit in certain cases, but this effect really still needs to be proven in randomized clinical trials. And as a side, I don't think that we have a significant number of well-designed studies, but more, published series and comparative series looking at intrastromal voriconazole versus amphotericin. And I think that it's the feeling of, I would say, a large number of corneal specialists that treat fungal ulcers frequently, that the rate of therapeutic keratoplasty actually has decreased since they've switched after the MUTT trial results. They switched to intrastromal amphotericin and intracameral amphotericin instead of voriconazole, and the rates of therapeutic keratoplasty have gone down. So it may be that even when injected locally, amphotericin may be more effective. Other oral antifungals that can be considered is posaconazole. So in summary, I think natamycin continues to be the treatment with best evidence supporting its use in filamentary species, and may consider oral voriconazole if the organism is fusarium. This was another study. Actually, this study is derived from the MUTT trial, from the same data. It's just another way of analyzing the data. And what they looked at is at the predictors for corneal perforations or need for therapeutic keratoplasty in severe fungal keratitis. So it's a secondary analysis. What they showed is that the depth of the infiltrate, the size of the infiltrate, and the presence of a hypopion are the three most important risk factors for perforation and need for therapeutic keratoplasty. So we consider that if we consider these high-risk features, we see that the rate of perforation is almost 60% compared to much less in the lower risk population. The size, when we consider a large infiltrate size, the size was more than 6.6 millimeters, and then the depth of the infiltrate was posterior 1/3 of the corneal stroma. So something to keep in mind. Just one quick thought about therapeutic keratoplasty in fungal keratitis. Today we're not talking about surgical treatment of keratitis, but mostly medical treatment. But if we have to do a therapeutic keratoplasty in fungal keratitis, I'd advise caution with postoperative steroids because it's the #1 risk factor for recurrence. What can we use if we don't use steroids? Well, we may have to use nothing and let this transplant fail if it has to fail. There's some small series looking at cyclosporin A as an immunosuppressant, and cyclosporin A also has some suppressive effect in fungal growth, so something to consider. All right, we'll switch gears now into viral keratitis. The diagnosis that we talked about for viral keratitis is largely clinically. We can use PCR. Topical antivirals, we have trifluidine. It's effective, but toxic to the epithelium. Acyclovir is just as effective as trifluidine, but less toxic. Unfortunately, at least in the US, is not available topically. Again, cyclovir has a broader spectrum against HSV, VZV and CMV. So this one's the most important, the CMV. And there's randomized clinical trial that is right now investigating ganciclovir for herpes zoster keratitis. Adjuvants for the treatment of viral keratitis, topical steroids. So the HEAD study, which is a study done several years ago, there were 2 of these studies looking at the treatment of viral keratitis or herpetic keratitis. And what we learned from this first study, the most important thing that we learned is that actually we do need to use topical steroids to help resolve stromal herpetic keratitis. Oral antivirals, we have 3 options: acyclovir, valcyclovir, which is the prodrug for acyclovir with better bioavailability and requires less frequent dosing. And valganciclovir it's a drug of choice for the treatment of cytomegalovirus keratitis, but it can have some adverse effects, including aplastic anemia. So just comparing the topical antiviral treatment, so if we look at ganciclovir, trifluridine, and oral acyclovir, they all have almost the same therapeutic effect on epithelial keratitis. There are new antivirals with novel mechanisms of actions other than nucleoside analogs that are developing, and we're looking forward to having something different for the treatment of infectious herpetic keratitis. So, which of the following antivirals is most likely to cause aplastic anemia? Let's see if you guys were paying attention. All right, yeah, and it is ganciclovir when it's given systemically, which is the way that it is given for the treatment of CMV and endotheliitis. The side effects is when this drug is given systemically. There are formulations that are topical that can be used for resistant, for example, herpetic keratitis, and these are, do not cause aplastic anemia or these severe side effects at the same rate. So what about prophylaxis? This is what we learned with our HEAD II study. And basically this classic teaching, very important, is that the use of oral acyclovir reduces the recurrence of stromal keratitis by 45%, so by a lot. Very important. But there are a lot of questions that have not been answered with this study. For example, we know that it reduces the recurrence of stromal keratitis. Does this still apply to epithelial keratitis? Or to uveitis? We pretty much think yes, but it was not assessed in this study. And what happens when the prophylaxis is discontinued? For how long have we had to use this prophylaxis? The study only used prophylaxis for 1 year, and then they tested recurrence after that. Recurrence at 1 year. So recurrence at 1 year was reduced by 45%. But if we had followed these patients for longer than 1 year, perhaps the reduction in recurrence could have been even larger. So we really don't know for how long we have to use it. Most of us use it sort of long-term for life, or until they haven't had an episode for several years. But this is a question that we don't have an evidence-based answer yet. We now have the ZET study, which is the study looking at the treatment of herpes zoster ophthalmicus. And basically, what this study wants to assess is the effect of valcyclovir as a suppressive agent for zoster keratitis. I think it's the sense from the corneal community that patients with zoster keratitis requires a high doses of acyclovir or valcyclovir to keep these eyes quiet. And this is what this study is actually looking at. So the patients that are included are those that have herpes zoster ophthalmicus, and then they get a recurrence. These are the patients included in this study. So it's a very small subset of patients. It is being difficult to recruit, but this is an ongoing study. And the third thing that is important for viral keratitis is vaccination. Again, this is something relatively new, not that new, but relatively new. And the idea is to prevent HZO and other zoster complications, it is recommended for all adults over 50. It does give, particularly the recombinant vaccine, these flu-like symptoms that are not mild. So most of us recommend, if you're going to get the vaccine, just get it when you know you can take a day or two off just to be on the safe side, or like on a Friday before the weekend, something like that. And I think in recommending vaccination, I think we as ophthalmologists play a large role. I think it's really important when it affects patients. It really gives a lot of morbidity, and we hear stories after stories how, you know, after a patient got herpes zoster, how their quality of life declined significantly. So we have 2 FDA-approved vaccines here in the U.S., the live attenuated vaccine and now the newer Adjuvant subunit vaccine, that it seems to be more effective than the live attenuated virus vaccine. And the CDC, again, recommends for all individuals over 50 with no contraindications. The studies looking at the live attenuated vaccine, the results showed that there is approximately a 50% decrease in the incidence of HZO with vaccination. And they showed that vaccination decreases the severity of the disease in patients who contracted HZO, even if they still got it after being vaccinated. And we don't have any data for the attenuated subunit vaccine yet, but we know it's more effective than the live attenuated, so we're expecting even better results. What about antiviral resistance? Does this exist? Well, actually, it happens relatively rare in immunocompetent patients. It's more a problem for immunocompromised patients, in which it could be as high as 36%. Russo looked in a prospective study, revealed that herpes virus 1 resistance to acyclovir is a significant cause of failure of prophylaxis in patients with HSV keratitis, and that is associated with longer disease duration. And so a lot of us, when we have a patient that is on appropriate prophylaxis and they have a recurrence with HSV, we may decide to keep them on a higher dose of prophylaxis from that point on. So this is something that could be done. But however, I think due to acyclovir resistance and this cross resistance between the different antivirals that are now in the market, I think an alternative of a drug that has a different mechanism of action for HSV is largely needed. What about prophylaxis after corneal transplantation? So there's been some studies, particularly this Cochrane database systematic review that looked at oral antivirals for preventing recurrent HSV keratitis after corneal grafting. And unfortunately, the evidence is not conclusive, but it does strongly suggest a decreased rate of recurrence and rejection rate and graft failure. They state that the effect of the prophylaxis may actually last longer after cessation of treatment. And this, again, is one of the things I was discussing before, that we don't have the definite answers to for how long we need to use the prophylaxis and what happens once we stop it. But there's no consensus regarding the most effective dosage or the duration of treatment in all the studies that we have published. But I think there's enough evidence, and I think this is pretty common clinical practice, that we all use prophylaxis after we graft patients with HSV. What about alternative treatments for infectious keratitis? We talked about that obviously the gold standard, the treatment of choice, is topical antimicrobials, but what happens when these don't work? Some people are really interested in collagen cross-linking for the treatment of infectious keratitis because it has an antimicrobial effect and because it increases the resistance to tissue necrosis. But what is the evidence? What do we know? We know that for bacterial infections, there's efficacy has been proven in vitro studies. There has been several case reports now that showed benefit in patients with recalcitrant corneal ulcers. There was a study that showed that reported on 16 patients treated only with collagen cross-linking, and they showed that 14 out of 16 resolved just with the cross-linking, and 2 out of 16 required antibiotic treatment. Another study looked at 32 patients, and these were randomized to antibiotic and cross-linking, that was one arm, versus antibiotic alone, that was the second arm. And this study also showed a benefit of cross-linking with a reduction in treatment time. What about, so it seems that for bacterial infections, there might be a benefit here. What about fungal infections? In vitro, it has not showed efficacy in vitro as a monotherapy. There is a randomized clinical trial evaluating collagen cross-linking as an adjuvant in the treatment of fungal infections. And actually, the early results suggested a possible increase in the perforation risk when collagen cross-linking was used. So what are the take-home points about collagen cross-linking? I would say studies on the effect of collagen cross-linking in infectious keratitis are limited. I don't think we could say one way or the other for sure yet. But there may be a benefit in bacterial keratitis. And I think larger randomized controlled trials are needed to determine the real efficacy of this therapeutic modality. And this is something new. It's kind of hot off the press, just published about a month ago in American Journal of Ophthalmology. And it's a concept similar to cross-linking, but with a different technique. It's called Rose Bengal photodynamic antimicrobial therapy. And basically, this case series was published where they looked at patients with progressive infectious keratitis that was unresponsive to standard medical therapy. They used Rose Bengal and to the de-epithelialized cornea for 30 minutes, and then it was followed by irradiation with custom-made green lead swords for 15 minutes. And they showed pretty good effect with resolution of several of their patients. And so again, something to be considered, to be looking out in the future as a perhaps new modality or an alternative for recalcitrant patients that don't respond to topical antimicrobials. So in summary, I think despite adequate antimicrobial treatment, infectious keratitis outcomes are often not favorable. Strategies focused in reducing associated morbidity should include prevention, better techniques for early diagnosis, better antimicrobials for resistant organisms, and therapies directed towards immune response modulation, very important, so that we can reduce corneal opacity and reduce corneal necrosis and perforation. And I thank you everyone for listening, and we can answer some questions. All right, I'm seeing them now.
Okay,
I'll read the first one. Is vaccination still recommended for people who already has varicella when they were younger? How about for people who already had HCO elsewhere? So I think for people who already had varicella, the answer is yes, because the immunity can be reduced over time. So yes, it is still recommended for those patients. For those that already had HCO, I mean, one could argue that their immune system was already boosted by that episode, and I don't think we have a definite answer for that. Any studies for oral fluconazole in fungal keratitis? So no recent studies comparing fluconazole, and I think we do use it orally, at least I do, and I do think it's effective sometimes. It's probably not the drug of choice, but sometimes because of insurance purposes, not covering other drugs, we have to use it, and I think it is effective or has some effect. But I don't think we have as good studies as the ones that we have in the MUTT trial. Next question. It seems like there is still a lot of to be defined when it comes to treatment and prevention of infectious keratitis. Are there any studies done currently that you think are promising? No, I don't. I think there's a study looking at the use of new things. I think a study looking at the use of steroids in acanthamoeba, that we should have results soon, but not, I can't think of anything else right now. How about corneal cross-linking in acanthamoeba keratitis? I think there have been some reports. Like I said, most of the studies, most of the evidence for cross-linking is just case reports or very small case series. There's no serious looking at acanthamoeba keratitis or cross-linking acanthamoeba keratitis, but there is some case reports. Any vaccine for HSV? Great question. Unfortunately, no. That's a big deficit that we have right now. It would be amazing if we could get a vaccine for herpes simplex. So natamycin is not available in my country. What would you recommend instead? I'm not sure what else is available, but compounded amphotericin and, of course, compounded voriconazole can also still be used. Compounded posaconazole or oral posaconazole are also options. These are all even more expensive drugs, but caspofungin also has shown some effect, good antifungal effect. Role of povidone iodine intrastromal. Very interesting. I don't have any experience with this, but if you do, please share. Very interesting. Can microbial infection cause corneal melting in 72 hours following an eventful small incision cataract surgery? And I think the answer is yes. Yeah, sometimes microbial infections can progress pretty quickly, particularly Pseudomonas of the invasive type. So I think, yeah, that is possible. Do you advise outpatient or inpatient care for microbial keratitis? I think that's a very good question. And in the past, we used to do inpatient care just for the frequent of dosing. Now we've realized, at least here in the US, that even if we put the patient in the hospital, the nurses don't have the time to give the drops every 30 minutes or every hour. And we still largely depend on the patient or the family members self-administering the drops. And so we don't think there's a huge benefit in having them, except when obtaining the medications or for some reason they're not able to apply them themselves and they don't have any family member that can reliably help. And then we will admit them into the hospital. This is a good comment. It says that backs a poor eye study in Nepal, Bhutan, India suggested effective primary prevention of fungal corneal ulcer, especially after corneal injuries acquired during harvest seasons in tropical climates, by distributing antibiotic ointment to village health workers. This is a very, very good comment. Thank you. Which concentration of vancomycin you advise for keratitis for bacteria that is resistant? So like we talked about, I think vancomycin 5% is the most effective. So if you're going for effect and fast effect, then you should use 5%. If you're worried about toxicity, then you can decrease the concentration and perhaps more frequent dosing. What is the best option for treating corneal involvement in Pseudomonas endophthalmitis? That's a hard one. I think, for patients with Pseudomonas, we always put them on oral moxifloxacin, and we treat them with topical tobramycin plus moxifloxacin, and then of course we'll do either a vitrectomy or we'll inject intravitreal antibiotics with ceftazidime, and I think that's our initial line of treatment. Good morning, doctor. Mostly with bacterial infections, keratitis, we use subconjunctival injection of gentamicin. Is it? I can't quite understand that question. I'm sorry. In earlier studies, how can we make in early stages, how can we make the difference between viral or fungal keratitis? Which analysis can we use for this? So I think that PCR is something that we can use for this. And because sometimes it is true, if you have a stromal keratitis, it's difficult to know exactly what is causing it. And of course, at the large medical centers like this one, you know, the patient gets to us after being treated for a month with therapies that didn't work. And so for us, it's like, okay, so it's not this, we know it's this. But at the beginning, you know, you see a patient and sometimes you don't know, is this herpetic keratitis, or is this a xanthamoeba, or is this early fungal keratitis? And I think PCR in the future will be very beneficial. So the sample taken for PCR, there's a special little probe that you use, and it comes actually with the tube where you put it into. That's how you take the sample. Unless you're taking a sample from the aqueous humor, and then there's a little vial where you will put it in. Role of subconjunctival antibiotic in microbial keratitis. I think we've used it, but I think intrastromal has a better effect. So if we inject, we typically end up injecting intrastromally. Is specular microscopy useful in diagnosing CMV endotheliitis? So we talked about confocal microscopy, and we talked about OCT, anterior segment OCT, and that's what's been published. But I think that you could see the owl cells in specular microscopy. So I would say that yes, it should have a use. I haven't tried it myself, but it sounds like an interesting idea. Okay, so the next question is, could we prepare, when you begin corticosteroid for the treatment of deep herpetic keratitis after beginning oral acyclovir, or when? Pretty quickly. I think that I have no qualms using topical steroids if the patient has adequate antiviral coverage. So if I think it's stromal keratitis, I start them both the same day. And I think that, can we use chlorhexidine for additional therapy in viral or fungal keratitis? So again, no studies to support this, but it's an antiseptic, and it's reasonable to think that it will have an effect. So if there's something that's not responding to your usual therapy, or this is all you have, I think it's worth a try. How can we determine patient with bacterial keratitis that needs collagen cross-linking for good treatment? So when do we decide to do collagen cross-linking? So, you know, there's two schools of thought. There's people that think that maybe collagen cross-linking could be the first line of therapy, so that then you don't have to worry about patient compliance with medication, or patient, you know, not being able to come back daily for checkups and things like that. And then, but most of the evidence that we have right now, as we discussed, is more, they use it's the last resort. Well, it didn't, you know, medical treatment didn't work, let's try cross-linking. But there's those two randomized studies that I talked about that are small, only 16 patients, but that used collagen cross-linking alone, and the one that used collagen cross-linking plus antibiotic both together. And then they showed that cross-linking may have a benefit. So I don't think we have the right answer to that yet. All right, so I think with this, I will end the webinar. I thank you very much for listening and for you know, tuning in on CyberSide today with Orbis, and come join us next time.